Well, hello everyone, and welcome to today's webinar, Growing Peer Support, Specialized Services at a Time of Crisis. My name is Tracy Sawicki, and I'm with the Peter and Elizabeth Tower Foundation. We're delighted to have so many of you with us for our third webinar in the Think Bigger, Do Good policy series. The Think Bigger, Do Good policy series started over 4 years ago among 4 foundations interested in playing a larger role in mental health and substance use disorders policy and advocacy at the federal, state, and local level. The series today has over 20 papers on topics ranging from suicide and crisis services, criminal justice reform, structural racism, and mental health inequities. And we encourage you to look at the papers authored by the best in the field of behavioral health and available at our website, thinkbiggerdogood.org. This work would not be possible without our partners, the PEGS Foundation, the Thomas Scattergood Behavioral Health Foundation, the Patrick P. Lee Foundation, and Psychiatric Services Journal. I'd also like to take a minute and extend a special thanks to Howard Goldman and Connie Gardner, who were the editors for this paper, and to Allie Ferguson of the Scattergood Foundation, who in addition to so many other roles serves as project manager for this series. So before I introduce our speakers, let's take a moment to review some housekeeping items. First, today's webinar is being recorded, and we'll share the link with you after the event is complete. We welcome you to revisit the content yourself and share it widely with colleagues and others who might be interested. All participants will be muted throughout the webinar, and with over 1,200 registered participants, we thought this might be wise. But we also want to invite your comments and questions. So please look at the Q&A feature on your screen. And if you think of a question for the speaker at any point, just type it in there. We'll be monitoring questions and comments throughout the event. And I'll either pose it to our speakers when it comes in, or I'll hold it for the Q&A session later on. And in addition to the webinar recordings, we'll be distributing the presentation materials, related articles and resources mentioned during the webinar, and information about upcoming events. So now about our speakers. So today we're fortunate to have with us Kelly A. Davis and Nathaniel Z. Counts, JD, authors of the paper, Growing Peer Support, Specialized Services at a Time of Crisis. Kelly Davis is the Associate Vice President for Peer and Youth Advocacy at Mental Health America. And Nathaniel Counts is also with Mental Health America and is the Senior Vice President of Behavioral Health and Innovation. Mental Health America is the nation's leading community-based nonprofit with over 200 plus affiliates dedicated to addressing the needs of those living with mental illness and promoting the overall mental health of all. Kelly Davis's lived experience with mental health diagnoses and trauma are at the center of her passion for transforming how we support individuals and change systems and services. In her role at MHA, she's involved in promoting peer support, peer certification, youth and young adult leadership, and college mental health. And she serves in an advisory role to Wellbeing Trust, the National Suicide Prevention Lifeline, and the Center for Law and Social Policy. Her colleague, Nathaniel Counts, leads policy research and advocacy centered around addressing social and economic determinants of behavioral health, prevention and population health strategies, and impacts of consumer technologies. Nathaniel's research is focused on aligning incentives to finance effective prevention and intervention in behavioral health, and it has been published broadly. In addition to his role at MHA, he's a clinical assistant professor in the Department of Psychiatry and Behavioral Sciences at the Albert Einstein College of Medicine. So behavioral health needs have been growing in this country for some time. And with this growth comes an increased need for comprehensive and engaging support for individuals with mental health conditions and substance use disorders in communities throughout the country. Today's guests will discuss how an investment, I just lost my notes there. Today's guest will discuss how an investment in the peer support workforce not only addresses the immediate and growing needs of people with mental health and substance use conditions, but can also help shape a future system of services rooted in empowerment, hope, connection, human rights, and lived experience. So welcome, Kelly and Nathaniel. We're so glad to have you with us.
Thank you for having us.
Yeah, happy to be here and happy to be with you all the participants too.
Great. So clearly there's quite a bit of interest in this topic, as shown in the number of people joining us today. And the term peer is used frequently in various disciplines. So I think it would be really beneficial if we started today ensuring that all of us on today's webinar have a shared definition and understanding of a peer. So Kelly, I'm going to call on you to start with giving us that grounding, if you would.
Yeah, absolutely. So I think that often in mental health and substance use disorder services, peer is kind of used as a euphemism for anybody with lived experience of using mental health services. But really broadly, peer is just anybody you identify with and have shared experience with. So there's peer support in mental health, but there's also peer support in other communities and conditions, whether that's people with diabetes, folks with cancer, new moms. So peer is kind of really a broad term for people who you have a shared identity with. But in the context of peer support in mental health, peer support specialists are people with lived experience of mental health and substance use conditions who receive specialized training to support one another. And, we were talking a little bit before the call about, we can share information and train people to really provide emotional support to one another. But one of the key and important pieces of peer support specialists and who they are and how they function and their values in the US really goes back to their history as part of the civil rights movement and deinstitutionalization in the 1960s and 70s. So peer support in mental health, the first instance we have actually is the late 1700s, 1800s in France, where leaders of the psychiatric institutions found that people who had left the institutions were better able to engage people who were currently in them. So there's a long history in mental health services, but in the US and broadly in particular, the modern peer support movement really comes out of when folks were released from the psychiatric institutions where there were a lot of abuses and horrifying treatments in combination with kind of the introduction of Thorazine in the psychiatric units. People were really released back into the communities, but folks found that these community mental health resources, similar to what we see today, were not adequately invested in. So folks really were left to come together to create their own systems of support. And then by the 1980s and 90s, peers were really, people with lived experience had been transforming mental health and how we talk about mental health, and were real drivers of this movement towards the idea of recovery. And then in the 2000s, we really started seeing an introduction of state certification. And over the past 10 years have seen a big rise in the certified peer specialist workforce.
That's great. Can you talk to us a little bit more? And thank you for that grounding. I think that's really helpful for all of us today. Could you talk a little bit to us today about, specifically what do peers do? Again, it would be helpful.
Yeah, so peers, there's an interesting history. I mean, as we see kind of peers and funding and resources are kind of split, just like we're seeing everywhere else of substance use disorder and mental health. I think there's a growing movement to integrate them. But peers, are working in addictions and mental health services, and they have a billion different names. So peer advocates, peer specialists, peer counselors, peer coach, peer mentor, all of these kind of terms are used somewhat interchangeably to describe peer specialists. So you might hear a different term depending on where you are. But at the core of is peerness, right? So connecting with people based on lived experience. And the ability to model recovery and inspire hope. So I can talk, my lived experience when I was 16 years old and I was hospitalized after a suicide attempt. If I had had somebody, a young adult there who said, I've been here and it gets better, the devastation that I felt and the inability to kind of navigate resources after for me and also for my family would have been so different. So that's kind of a critical piece as well, is kind of systems navigation and information about your options and tools for you to advocate for yourself are big parts of what peers do. So making sure that you're able to connect to different resources in the community, but also have an understanding of what resources are available to you. And the fact that, we often talk about peers as increasing, people talk about treatment adherence, but I think the real function of peers in that capacity is providing people information about their well-being and empowering them with the tools to advocate for themselves so that they have resources that better meet their needs and they're more able to engage in those resources. So, self-help skills, connecting people to community resources. Peers also do, goal setting and wellness planning. One of the really interesting things about peer support is, as we often know, there's a big intersection and overlap between folks who have addictions challenges and also people, sometimes related to the psych meds that are prescribed to people, diabetes or other chronic health conditions. And there's also a lot of research about peer support, not only increasing hope and empowerment and connection to community, but also helping folks to better manage other chronic health conditions too. So not only are they empowered with resources and tools to improve their mental health and to engage in community in whatever ways is important to them, whether that's education, employment, church, arts, all the things that are important to people. But they're also able to also improve their physical health and well-being as well.
Mhm.
Yeah, it's funny when I was thinking about, as you said, what if you had someone there, in the idea of carrying notes, so when someone's leaving an emergency department after a suicide attempt, sending a note home to them afterwards is hugely evidence-based for preventing repeat attempts. But basically, it's imagine if that was a whole human being and not just a single note, someone to meaningfully provide support, both emotional and informational support to you throughout your journey. Imagine, how incredible that would be.
Yeah, I think, go ahead.
Oh, no, yeah, please.
I think a lot of what peer support brings is this whole human perspective where, it's not to say that different members of clinical care teams, they all have specific skills that are beneficial to people. But I think the peerness really honors people's humanness. And yes, you can have a psychiatrist. Yes, you can have a primary care physician. Yes, you can have a counselor, but as a hub and a person for you to talk through all of these things through, and better understand yourself and what's important to you in this broader context. And the fact that, we're relational beings and it's really important for us to have somebody to connect with and somebody who can spend more time with us than, 15 minutes, right? Which is often, when you're talking to your psychiatrist. Or, an hour is somebody who I often talk about, I work in college mental health. And it's really exciting to get people. I mean, so many people don't have basic resources, right? That takes 6 months to get that 15 minutes with a psychiatrist, or, you have an hour a week with your therapist, but I had to be in my head literally every hour of that week besides the 1 hour with the therapist, right? So what are we doing to comprehensively support other people when they're not in clinical services? And I think peer support is a really big part of how we address that, especially because people with lived experience, it's really obvious. It might not be obvious to folks who are pieces of the puzzle in how we support people's mental health, but the flaws of the system and how incomplete it is are very obvious if you have to go through it for yourself or for a family member. So I think this lived experience is not only important for connecting people with services and empowering them, but I think it's also important when we talk about policy, when we talk about programs and organizational leadership, peers are really able to, from that lived experience, better design resources and better contribute to the way that we create policy and implement resources.
Great. You made me think of a couple of things in your comments, and one has to do with, developing this workforce and finding individuals to serve at peers. But also I know from your paper and from hearing you speak before, this idea that, peer run organizations, and you talked about, the integration a little bit about, having a support peer, if you will, on a team. And that's, again, I think that's interesting to talk about. In what ways what does that look like? How does the integrity of a peer, right, remain when you're in a clinical team or part of that team? But if you could first maybe talk about, expanding the workforce and this idea of peer run organizations and the importance of that versus the having perhaps peer run programs within organizations, and that distinction.
I keep starting. You want to go ahead and start, Nathaniel?
Oh, no, yeah, no, take it away.
So I think one of the things that's really common is there's all of this exciting talk about peer specialists, and then we throw them in organizations that have no training about what peer specialists do, that do not know how to supervise peers, that do not pay peers well, and then we say peer support doesn't work. So I think that there's, a real need for organizations to do this work effectively. There needs to be upfront commitment. And we talk about, later on when we talk about our policy recommendations, that needs to be included when you're thinking about payment and reimbursement, because if people don't have incentive and have the finances to really do the leadership work that's required to integrate peers into your work, then it's not going to work effectively for the folks who are receiving support, as effectively for the other for the clinicians who are as part of the staff. But most for peer specialists themselves, they burn out, they shift into roles that are not peer roles. So I think that this commitment to training is really important. And one of our recommendations as well that we talk about is this need, this preference from a lot of peer organizations to be the employers of the peer specialists. Because as I said, a lot of times the folks who are supervising peers have no training in what peer support is, and they certainly don't know how to supervise peers. So both from a making sure you have adequate supervision perspective, but also making sure that you aren't drifting into kind of a clinical mindset or clinical services. It's really important for folks to have that supervision and outside perspective so that they can connect to their peers in providing peer support and talk to them about the things that they're seeing. Because, I think that we all, just talking about humanness, we all want to fit in at our jobs. We don't want to cause chaos. And a lot of what peers are doing is you are put into this environment to disrupt this environment, right? Or to at least cause people to think a little bit differently. And you might have to challenge the ways that staff talk about people. And you might have to push back. And I think that's really an art. But having these external organizations and providing reimbursement for peer-run organizations, not only ensures the kind of ethics and boundaries of peer support, but it also gets at this other piece of like being discharged to what, right? If there's no community services, if there's no really engaging place for people to be, we're really setting people up to fail, or at least to not flourish, right? And live the lives they want, because the point of peer support is not treatment adherence. It's not to get people to, stay engaged with services indefinitely. It's really empowering them to live the lives they want. And I think also having these community-based organizations where people are making, having somewhere to go, having exactly Marie, quality of life, having places where they can go and where they can learn these skills that do not necessarily require like direct Medicaid reimbursable services, but really are more about this authentic community and resources that the history of peer support services is rooted in.
And I think the other like movement that this kind of like outside employment, like community-based organizations employing peer supporters that run the organization themselves, it also goes into the current movement towards community power building, community wealth building. Because like most industries are in some sense extractive, and healthcare is no exception. A few people at the top make most of the money, and then the people at the bottom make some tiny fraction thereof. And we'll get into this, I think, a little bit later. We talk about reasonable reimbursement and value. But you have a chance to be an outside organization. You have the chance to lead and distribute wealth and power more equitably, and kind of like also like not only within mental health, I think set a standard for how power should be shared, but just more broadly, I think, across communities. So we don't just have people kind of slotting into extractive industries, but instead kind of like building and nurturing their own initiatives.
Yeah, I think to that point too, we're also having peers as part of the workforce, not just as kind of an addition or expander of the workforce, but really as change agents of the culture. I think also helps. We talk a lot, and there's a lot of conversation about measurement in mental health. And somebody said quality of life. I think peers and the perspective that peers bring helps us to move towards what are we measuring, and is what we're measuring important to the people receiving the services, right? So we talk about peers as reducing hospitalization, emergency department usage, depression, problematic substance use. These are awesome and important and great, but are people sentenced to a life of maintenance where their wants and needs and aspirations are not important to the mental health and the mental health services that they're providing? And I think that peers are really important in this kind of policy conversation around not only how much we're reimbursing, but what we're reimbursing for and what we're tying it to. Because the peers, as part of my kind of background, I've done a lot of work in positive psychology, and there is this something called the dual continuum. Corey Keyes and a researcher at Emory developed it, and it talks about there's a dual continuum of mental illness to not mental illness and mental wellness to languishing. And as somebody who was diagnosed with a serious mental illness, bipolar disorder, right? In many ways, I have better well-being than people who have no psychiatric diagnosis. So I think too, peers bring in this understanding is it's not, there's reduction of things that we can all agree are not great, which is like keeping people for years in a hospital, right? People, showing up in the emergency department. But I think also, there's a positive side that we should be aiming for too. And whether or not you have psychiatric symptoms, whether or not you have, even if I screen moderately severe on the depression PHQ-9, there's ways that you can build well-being into my life, and there's ways that you can support others in creating well-being in their own lives. So I think too, it's not only the money, it's not only the how do we equitably invest in health and well-being in communities and shared power, it's also what are we moving towards, and how can peers help shift this movement to what we understand. It's like with suicide prevention, right? And it's like you don't just focus on clinical interventions to reduce suicide. You make a world where people don't want to die. And it's a similar thing, is what are we moving towards, not just what are we moving away from.
I think the broader commitment also stops it from like this kind of like programmatic trap where you like implement like one part-time FTE peer, and then if they're not like literally magic, you defund the entire program. And like a much more like, I think it is like a broader commitment towards power sharing and centering the perspectives of those lived experience, and it's not treating it like, I don't know, just another program that has to have like kind of like high payoff where you give up on it the next day.
I mean, clearly you're talking about this as a movement, which was something that you've been bringing this up throughout the course of our conversation today, that this really is a movement, and you're looking again to expand the integration of, peer support services throughout. And we've got a couple of questions that I think are probably appropriate right now. So one here is like, how would you create a way for peers to have an opportunity for advancement while not losing the principles that drive peer support? I mean, you did mention organizations that are led by peers, et cetera, but what else might you say to that?
Yeah, I can start, and then Nathaniel, if you want to add. So that's actually one of the recommendations that we have in the report, is there's a lot of conversation in the field of peer support. Minnesota already does this. I'm currently working on a paper with H&H in New York City about how do we make sure that peer support is not just an entry-level job or just treated as a pathway to do something else, like become a social worker. And one of the solutions that we talk about is tiered reimbursement and levels of certification. So oftentimes, you go through certification throughout the US for peer specialists. In order to bill Medicaid, you have to go through your formal state certification process, but the levels of training required ranges from 35 to like over 100. And the levels of experience required ranges from 0 to 2,000. So we're really talking about like a wide range of experience and training that folks have when they start in the field. But then like I think the question references is there's no next step. And we think that tiered reimbursement, but also tiered certification, gives folks an opportunity to, if if peer support is something that you just want to do on a voluntary basis, we don't want to take that away, right? If peer support is an entry point when you haven't been working and it's a good pathway to do something else and get some work experience, we also don't want to take that away. But many people who work as peer specialists, just in any other career, if there's no opportunities for advancement, they leave. And especially considering the low reimbursement rates and wages that peers face. So at MHA, one of the things that I work on is the National Peer Specialist Certification that requires a minimum of 3,000 hours of experience. It's examination based, and it requires prior state certification, or which is currently exists or is in the process in 48 states. California, I don't know how long it's going to take them because they have massive amount of peers, and that grandfathering is going to be hard. But I think that, you know, these levels of certification give people the opportunity to say, okay, I have a certain amount of experience and commitment to the field. I'm going to take this take this to the next level. And kind of in the H&H model, they have level 1, level 2, and supervision. So we're giving people pathways. And then I think this other piece as well is that, you know, making more money and having a higher tier of certification shouldn't be the only pathway for peers, because peers have really important things to add as, you know, leading training organizations, as leading departments of, you know, leading peer services for the state, leading, you know, talking about like Karis, right? Leading the Karis Myrick, leading departments of consumer affairs at SAMHSA. So there really are, you know, there's room for advancement and tiered reimbursement and certification within kind of formal direct service environments. But I think too, we need to also have more conversations about the value that peers add in broader leadership positions in the field of mental health and in substance use disorder services as well.
Yeah, and I was going to say, I think it also plays into, like, on the value point, like the value-based payment kind of perspective as well. Because I mean, the one thing that would make no sense, right, is say you're like, we even have tiers of certification, and you're like the lowest certified tier of peer, and your outcomes, you know, you dramatically reduce costs and improve clinical outcomes by a huge percentage, and people are flourishing. And you get paid like a tiny fraction of someone who's not even practicing evidence-based medicine, for example. That is the world we live in right now. That doesn't make any sense, and that's definitely not where we should keep heading. So I think you know, more fairly compensating people based on the value they're producing has to remain a sort of like key commitment of all of this. And then in the sort of like career ladder part, I also think not only just in like consumer affairs departments, but also like healthcare management and health plan management. I mean, I think that's like a lot of a big feature that a lot of companies are trying to tout, is you can start anywhere and end up at the top. And peers should have the same opportunity too.
Yeah, I think to that point is that we don't, at least at MHA, and I think a lot of us want to create kind of an underclass of workers who we exploit. Because when we're talking about like value and value-based payment and all of these things, often peers in their role reducing emergency department usage, in their role of keeping people out of psychiatric hospitals, not even talking about the other outcomes, are really profoundly reducing costs. And I think that it's pretty horrifying to have peers making such intense contributions to the field and services, and then still paying them like $10 an hour. Right. So I think that there's a really big equity conversation that needs to happen there. You know, peers kind of understood the idea of why value-based payment should happen before it was a broader conversation, where it's like, we need to invest in the things that matter to people and the things that make life worth living. And that's actually what improves well-being and keeps people out of the hospital, and that when they don't need, you know, when they don't need to be there, and those kinds of things. So I think that, you know, it's not just we think people with psychiatric diagnoses provide an important service and all of those things. It's like, we can quantify the value that when adequately supported, peers provide to teams and peers provide to people. And it's you know, kind of ableist, right? Or like kind of ableist classes, right? To say, you know, people who don't have PhDs should be reimbursed at a very low rate, even if they're making these radical contributions to the field.
Well, I think you've really begun to talk about some of the barriers and some of the hurdles that come with trying to, you know, establish peer supports in our communities. And I think it would be a nice way to segue right now. Nathaniel, you also mentioned, in the 5 steps that were outlined, in the paper, that people can take to really begin to further support this whole movement towards, peer specialists. So would you take a moment to cover those 5 steps and give people, a brief overview of what they are, and again, give us an idea of those actions? That would be helpful.
Yeah, do you want me to start with that one, Kelly?
Sure.
So our 5 steps. So the first one is protecting against state and local budget cuts. We'll start with that one. This was really, there's state and local governments are facing massive budget shortfalls. And often the first thing to go is the last thing to be added to health benefits is the first thing to go, regardless of their value. And so this is really resist the temptation to start cutting things that work just because you're facing a budget shortfall, and think about the sort of longer term, is this producing value and worth keeping? And are we being sort of, was it penny wise, pound foolish by cutting it? And the second part is, in order to build that case, looking at more evaluation and research around it. And this is really hard because it's kind of like asking, do doctors work? And it's that is not a logical question. Doctors do a lot of things. Some specific interventions work and other ones don't. And peers are the same thing. You could try to test a model, like the Bridger model, where you have someone leaving the hospital and you give them continuity of care. But the concept of peers is extremely hard to evaluate, I think, which is a big challenge. So more research on how that works will help build the case for why it's worth investing in.
Yeah, and I think, oh, go ahead.
So yeah, no.
And I think too, having a longer timeline and collaboration of, we talk about states kind of doing research into how, systems level outcomes for integrating peer specialists. But if you think about what peer specialists do, which is sometimes, a lot of the research on cost reduction that we talk about comes out of the Bridger model that Nathaniel is talking about, where you have folks who have a recent history of a lot of hospitalizations and emergency department use, and then you help them transition back into the community. And that reduces costs by a lot. But if we're kind of integrating peer specialists more broadly, part of what peers do is connect people to services, and that costs money. So you might see, if you're kind of introducing a service that's helping people navigate a system where they're actually accessing the resources that are important to them, I think that cost looks a little bit different. And I think that there needs to be a longer timeline for how we determine, first of all, that saving money isn't the only thing that should be important, but also we do have a finite amount of resources, right? So we are kind of looking, I think it's important to look at a longer term than, a year of, because peers might increase the cost because people are actually using the things that they need, as opposed to kind of being left to struggle. And if you show up in jail or the emergency department enough times, we might do something for you.
Absolutely. And the next one is ensuring adequate funding for peer special services, which is sort of the core issue that I think that people first think of, which is really I think one of the biggest issues is making sure that for reimbursement is adequate and covers the full range of what it means to be a peer. Because usually you have to kind of shoehorn yourself into these little codes. And then it needs to be aligned across payers as well. So having one Medicaid plan pay one way and a different one pay a different way, and commercial does things that's, nobody wants to bill 1,000 things and nobody's going to bother. And they've begun trying to solve this in primary care. So there's these, the state will run these collaboratives where you bring different payers together to think about how should we actually reimburse for these things. And so making sure that there is a consistent and fair payment framework that does cover, fairly compensate people for their time. The kind of tricky thing there is it's actually an antitrust violation for health plans to talk to each other. That would be sort of rate setting. They're not allowed to talk about how much they're going to pay and how. So you need a state, the government or some sort of intermediary to come in and have that conversation and protect them so that they can figure out how to do that kind of payment. The next one is build and expand the organizations that employ peers. Oh yeah, please.
Then, do you want me to add? Can I add a little bit?
Please.
So I think the other thing as well is that peer services are predominantly paid for by Medicaid and state and local money, which means that, you can cover peer specialists as part of Medicare Advantage, but peers are not covered providers under Medicare. And also, we are seeing an increase in the use of peer specialists in commercial insurance, especially around opioid use disorder, and on the substance use side, but not necessarily on the mental health side. And I think in the kind of I like to bring in kind of my lived experience and to help illustrate some of these things. And I think what often happens for folks is many of us start out with commercial insurance and then do so poorly, that our lives are impacted in a way where we end up on Medicaid, which is what happened to me. And I think MHA, if you look at our logo and our website, we have this before stage 4 philosophy is what we talk about, where mental health conditions are the only health conditions that we wait until crisis to deal with. And I think that if we had more coverage and more access to peer services earlier for folks, and particularly talking about commercial insurance, it would, kind of prevent a lot of things, that a lot of the distress, the 10 years between starting experiencing mental health challenges and getting access to treatment, that's so common for folks.
I left off too. One other thing is billing is awful and everyone's trying to move away from it. So going back to the value-based payment thing, I think, having states and commercial insurers work together to lead better value-based payment models that incorporate peer support organizations as providers. And I think generally there's a bigger movement towards healthcare contracting with different kinds of outside community-based organizations to provide services like housing or food. And so I think fitting it into that framework, instead of I really feel like it's been in this like strange programmatic silo and not getting the benefit from this larger movement towards community empowerment. And so, fitting it into these larger conversations, I think will be hugely impactful, as hopefully we all begin to move away from CPT codes, but they're the evil of today. So we'll need to work with it. Then build and expand the organizations that employ peers. So this is a lot of recommendations around training and certification. This one's way more focused on treating peer support organizations as small businesses. So this was kind of specific to COVID also, there's all these opportunities around helping small businesses get funding and stay afloat and do sort of the legal aspects of being a small business. And peer support organizations are small businesses that are part of community development and growth. And so I think putting them into that framework would help them get better access to the economic resources they need to grow and thrive. So, usually we just try to think about getting different Medicaid funding streams, but there is this entire other world of community development that can really help, I think, especially with the business acumen, because I think running a business is a very different skill set than being a peer supporter. So helping with that would be huge. Then, onto the training and certification recommendation. So we need, one of the biggest challenges is there's just not that much funding for getting training to become a peer support specialist. And there's not frameworks around levels of certification. Everything we've kind of discussed isn't recognized. For commercial insurance, they want some kind of way to know that you're going to provide high quality care. Doctors have MDs or DOs, and each group has some sort of designation. And the one that state Medicaid uses might not be sufficient, especially as Kelly alluded to the variation. So increased funding and formal frameworks that make that feasible, and especially making it possible to go across state lines, because it's awful to get fully certified in one state and go into the other state and nothing you did applies, especially as we go on to a virtual world. Which is the last recommendation, is promoting access. Yeah. On in.
So I think two things. So first is that increasing training, certification, ongoing education. When you look at the peer support workforce, you see a lot of problems that are also reflected in the broader behavioral health workforce, especially around equity. So the peer support workforce, similar to other providers, social workers, is really overrepresented by white middle class white folks. And I think that there's not a lot of investment and resources in the investment in diversity and equity and engagement and peer support. And I think too, this is not just kind of it includes racial equity and racial justice, but it also includes LGBTQ plus, in equity, right? It includes working with young people, working with older adults, working in criminal justice. So I think that there's all sorts of populations that are not as adequately invested in and engaged in the peer support workforce. And I think part of that is initiatives to kind of create broader engagement. But part of that too is, we talk about in peer support, engaging people with lived experience. And I think, it's important to invest in and empower folks from different backgrounds with different identities to get more involved in this work, and to better understand what are the problems within the work that are keeping people out. And I think, as Nathaniel said, peer specialists aren't magic people. And many of the problems with homophobia and racism and, white supremacy are still in the field of peer support too, because they're also people. So I think there needs to be a lot of investment both in addressing these barriers and structural issues, but also more engagement and diversifying the field. I would also say as well, so we talk about, career advancement opportunities, higher levels of certification, continuing education, and investment in workforce issues. But I think as well, one of the things that has happened is while there's investment in getting people trained and certified, there isn't necessarily as much investment in understanding how and why the trainings work, but also understanding what happens after people get trained. So if we're not investing in the other issues, right, they're all interrelated. If we're not investing in employment opportunities and reimbursement, we're really training people to nothing. So we need to understand, what are the barriers, investing in understanding training, but also understanding the barriers around what happens to people after they receive training. Because I think that there's also, it doesn't make financial sense, but I think in peer support, there's also kind of a special cruelty about training people to share some of the most devastating parts of their life, and giving people hope that they're going to be able to use their story and to support other people, and say, you did 80 hours of training and got 500 hours experience, but there's no jobs for you. And I think that has to be, when we're talking about investing in training, we have to be talking about, yes, investing in training for peers, investing for training in organizations, but also making sure we're understanding, what happens after. So we're not doing this, we put all this money in workforce initiatives to train people and then train them to no jobs or no opportunities to actually work.
I think like a second part of the funding recommendation too is making sure that some of it goes towards healthcare organizations to help with the kind of like setting up the supervision and integration aspect as well. Because like Kelly was saying, it's not so straightforward. I mean, just like picking up a trained peer and putting them in is not, or even like creating a collaboration with a peer support organization is not so straightforward. And so like having learning collaboratives of healthcare systems that get reimbursement to work on this issue and then hire the trainees and all of that, I think then can begin to build like a serious pipeline of organizations ready to accept this developing workforce. And then just really quick, sorry, the last one was the virtual peers. So telephone, web enabled, there's a whole world of digital health happening, and peer support's a clear part of that as well.
One question that's come in, and then there are a few. How do you think that the American Rescue Act, in what ways might the dollars that are available through this act may have opportunity to support the building of this workforce? Is there an opportunity there?
Yeah, absolutely. I mean, there is just quite a lot of money coming for mental health and substance use, and just for small businesses. So I'd say the opportunities are enormous. There's even specific measures focused on training peer support. So it seems like a total fit. I think the biggest challenge is going to be, it's just so much more money than has been spent, and there's not like necessarily infrastructure in place to use it wisely, quickly. So I think the big chance is going to be, really working with the states to help them build out this capacity quickly, when it's been just so underinvested in for so long. So I think it'll be, mixing these different kind of grant funding streams, working with Medicaid, working with the economic development measures, kind of all together to elevate the opportunity with peer support.
Yeah, and I think, like Nathaniel's saying, it'll be interesting to see how the money's spent down when it's so much more than folks are used to. But I think too, there's also a really important piece here around making sure that we're integrating the kind of some of the point. You know, we didn't make all the points. There's plenty of other people who have great things to kind of to contribute, but making sure that many of these points and the perspectives of people in the field are included in how we decide what we decide to do with the money. And then I think, you know, more broadly, focusing on, Nathaniel and I talk a lot about accountability, right? Where it's like you know, to whom are folks accountable for how they are implementing these resources? And I think when we're talking about, you know, community power building and all of those things, we need to be talking about when there's such big investment, when there's such extreme distress among Americans, especially young people, that we really have an obligation to make sure that resources, yes, there's more resources, but that they're not used to perpetuate the same problems that we see now, but are really integrating a lot of the new and exciting things happening, but also a lot of the values that the peer support movement brings. So the importance of kind of voluntariness of services, right? The importance of, like, for example, right, investing in you know, we don't want people showing up in the emergency department. So investing in kind of crisis diversion, investing in resources that give people more options than calling the police when they're in crisis. So I think that there's a lot of big structural issues that we've started to talk about and that are becoming increasingly, I guess, as somebody who's been in like the peer support movement, increasingly mainstream, and that those need to be part of the conceptualization, the implementation, and our understanding of what works and what is not working for people, and how we can make changes based on that, as opposed to based on how we've done things.
Terrific. You know, you've answered many questions have come in from our participants today, and you've answered quite a few of them in your dialogue going back and forth, but there are a couple that are very specific that I, in our last, 10 minutes together, would love to throw out to you. And so a question is, are there family and or caregiver peers that are complementary to the peers you're talking about today?
Yeah, so family peer support, there's also an organization called the National Federation of Families. They have a national certification for family peer supporters. But in many states, family peer support is reimbursed, but typically for youth and transition age youth. So it's typically for family members who, or it's most commonly for family members of kind of youth and young adults. There's also, you know, within peer support, there are kind of, I mentioned earlier, so there's broader general peer support, but there's kind of specializations for youth and young adult peer specialists, family peer specialists, folks who are working in criminal justice and corrections, folks who are, there's kind of the additional certification and the more specialized training. So folks who are working with older adults. So I think that there's kind of a lot of different pieces of how we support people that require additional training, but family members are a big part of how people thrive their relationships with their family members and those kinds of things, and how their family members also know how to navigate services and resources. And I think too, we talk about one of our colleagues, Debbie Plotnick, who is a big person in policy, talks about her experience as a family member. And I think some of the kind of values of the peer support movement around voluntariness, when it's really hard to, sometimes maintain those boundaries as a family member, when you're like, I just want my person to get help, and how to navigate, okay, my child is an adult, right? This person is an adult, and how do I support them in ways that are empowering to them and that don't take away their agency, but also that allow me to support myself, because it's hard to support our family members, especially when they're in crisis. And it can be really hard to watch someone that you care about struggle so profoundly, and also face the consequences of kind of an infrastructure that inadequately supports everybody, no matter what kind of place in the system they are, whether they're receiving outpatient services, whether they're hospitalized, they're in residential treatment or criminal justice. So I think that there's there's a lot of important resources for family members as well that are being invested in. And I know we're following up with documents. There was a document that came out, I think, last year about reimbursement rates and processes for youth and family peer support across states.
Great. We'll make sure we include that with materials that we send out to our audience today. There have been quite a few you've touched on anyway, training for peers. And what we've seen are a lot more questions coming in about recommendations for train the trainer or supervision of peer mentors, more specifically. Are there any best practices around that particular type of supervision?
So I think a lot of the existing trainers are doing this work as part of the national certification, particularly to address California. We had to create two pathways. So one is state certification and one is completion of an approved training. So those are through organizations like Depression and Bipolar Support Alliance, intentional peer support, some of these different groups, and I can send out a list of those trainings, but who are already doing trainings, who have been doing trainings, and who, after you go through it, they train you to train other people, right? But I think what was the other point that I was going to make? So NAPS, formerly INAPS, the National Association of Peer Supporters. So they developed the national practice guidelines for peer specialists and recently have put out practice guidelines for supervisors of peers. So they, somebody mentioned it in the chat. So they also are doing a lot of work on the supervision piece because it's, in addition to reimbursement rates, supervision and inadequate supervision really contributes to burnout and folks leaving the field.
Mm-hmm. Great. At this point, I'm going to look at, I'm looking at our time. It is flying by, but there's a question here that can you talk about the similarities briefly between peer support specialists and community health workers?
You want to start that one, Kelly? And then you want me to start? Yeah, so I think the biggest difference, so the similarity is they're both not sort of they're newer categories of labor from medicine's perspective, not from, as Kelly said, the historical perspective. And they both kind of take on these roles that are totally unfilled by clinical care. And both, I think, have a range of duties. There are certain kind of boxed models of community health workers, like the impact model, but I think they do take on a whole range of education about health opportunities to directly providing some level of intervention like stress management. So in the same way, I think peer support shares a lot of roles in accessing resources but I think the biggest difference is sort of one, the idea of them being a peer. It is the key to this is the relational aspect, someone you identify with that is sharing their experience, and that they're helping you navigate a certain set of experiences instead of the more public health focus of community health workers, which is attending to community level needs. So I think there are both similarities, but then also differences. But they're also, I think they're also part of the same general movement towards democratizing healthcare and sharing power. And when you read writings from the community health worker folks, it's has a lot of the same undertones as the peer support movement as well.
So as we begin to wind down, we're almost at time. We always ask our speakers to take a moment and give one final recommendation that you'd like to leave folks with. We've talked about advocacy, we've talked about your steps that we can take, but if there was one piece of advice or one final thought you'd like to leave our audience with today, each of you, take a moment and let us know.
Do you want me to start, Kelly?
Certainly.
I think the one thing that comes to mind is, especially with the American Rescue Plan, is using this chance to kind of if you don't already organize some sort of coalition kind of type thing focused on mental health in your community or state, and include a peer support organization center peer support as part of that coalition. Because I think we do need structures in place to more wisely spend the resources that are coming down and have accountability. And all of the kind of issues I think peer support's facing require this kind of collaboration between the state and between insurers and between healthcare. And so I think that if we kind of create shared goals towards improved community or state mental health, and then include peer support in the conversation, I think that would begin to address like the full range of issues we brought up today. And it's easier when there's a bunch of resources instead of a resource scarcity and everybody's fighting each other.
Thank you.
Yeah, I second that, and also pay peers, like pay them well. Pay people living wages, increase reimbursement rates, because folks, when they're so low, it also disincentivizes employers and providers from providing the services. So I think that one of the biggest things that we can do to increase folks working in the field is to make sure that people are paid living wages, and there's a lot of conversation within the field as well. And I think that's the movement towards legitimizing the field and all of those things. So pay your peers, increase reimbursement rates. People deserve living wages and they shouldn't be exploited, especially if they're improving services and reducing costs.
Yeah, that's why we don't have a workforce shortage in Wall Street finance.
Here we go. Well, thank you, both of you, for those last comments. This has been a terrific hour. I want to thank you and everyone who joined us for today's webinar. A special thanks to both of our guests, Kelly Davis and Nathaniel Counts. Thank you so much for sharing your insights and expertise. So appreciated.
Thank you so much for having us.
Yeah, well, we'll have you back if we can do another webinar, because clearly we didn't cover a lot of the questions that were asked. An hour doesn't give us much time. But I want to let everyone know, as a reminder, we'll be sending a follow-up email shortly. It'll contain links to the webinar recording, related articles and resources, a feedback survey to let us know how you thought it went today, and registration link to our upcoming webinar. And our upcoming webinar is Enhancing the Capacity of Mental Health and Addiction Work, a Framework. Anita Burgess will be giving that session, and that will be, just a moment, my Zoom just went a little odd. There we go. On Monday, April 19th at noon will be our next session. So from all of us here at Think Bigger, Do Good Policy Series, and a special thanks to our guests, have a wonderful day, and we'll see you at our next webinar. Thank you again, Kelly and Nathaniel.
I would just add, if you want to talk to us, my email is kdavis@mhanational.org, and Nathaniel's is similar, and Counts. So would love to, if people have follow-up questions in addition to the resources, we're always happy to talk to people as well.
Terrific. Thank you so much. Have a great day, everyone.